Morning, everyone. I think we're going to go ahead and get started. Thank you all for being here. This is actually our last speaker program in this series of speaker events, and we're really excited to have Janice Meinert from Pennsylvania Health Law Project and Aaron Nienhauser from Pennsylvania Health Access Network. They're going to talk about updates with Medicaid services in Pennsylvania. So I'll let them tell you all a little bit about themselves. But before we get started, just a couple of housekeeping items. There's coffee and bagels in the back. Help yourself. Our restrooms are kind of on the other side of this wall, so you can go out the front door or the back door, to get to the restrooms. I think you've all signed in. Does anyone need slides? There's a set of slides for each of the speakers this morning, okay? And at the end of the program, if you could just fill out the survey. I think I gave everyone a survey. We're able to do these programs because of a grant we have from the United Way of Southwestern Pennsylvania. So in order for us to just let them know, what we're doing and how we're doing, we ask people to fill out the survey. Let us know what you think. And if you have any suggestions for future programs or, any feedback on today's program. So, and then the last thing I wanted to let you know is for yourself and to share with some of your families is we are running a series of 5 speaker events starting next month with Heffron Tillotson on financial planning. And they're going to be held at 5 different area locations. One here at Achieva, one at the Arc of Westmoreland, and one at 3 of the Heffron Tillotson offices at South Point, out in Canonsburg, Westmoreland, Arc, and Wexford. So I have, there's flyers up here, with the dates and times and information, and everything is on our website as well. So we just redid our website at achievafamilytrust.org, and anything can be found on there about the speaker programs, and we will upload your slides to that website after the program as well. So if anyone wants to go back and listen live, they'll be able to. So. Okay, Janice.
All right, thanks, Patty. Good morning, everybody. I am Janice Meinert with the Pennsylvania Health Law Project, and I'll spend just a couple minutes talking for folks who don't know, who we are, what we do, how we can be a resource to folks. But just in terms of the overall presentation, I'm going to do, and Aaron and I kind of, coordinated our presentation for the day. So I'm going to start the presentation with more of a Medicaid 101, just, Medicaid basics kinds of things, both federally and in Pennsylvania. And then Aaron's going to get into, kind of more details around, what's happening, potential concerns perhaps regarding Medicaid. So first, just in terms of the health law, and I'm sorry, let me just back up and also say to folks, please feel free to ask questions, as we go. That's always my preference for me. Erin can let us know what she prefers. And then we'll just also be, paying attention to time as well. So I always say if we're only on slide 3 and it's close to 10 o'clock because of lots of questions, then we might curb questions. But otherwise, I certainly prefer, just for the presentation to be more interactive. And certainly don't let me get further into something when, you were confused about something I said 3 slides ago. So feel free to, to ask questions as we go. Folks on the webinar, please just give us information through the chat box. And then I'll get a signal from the back of our room and letting us know that we've got a question, through the webinar.
Yes, you can just repeat the question back if anyone in the audience asks.
Yes.
So then the people online will hear what the question is.
Absolutely. So as Patty said, and if there are questions in the room, I'll do my best to remember to repeat the question so folks on the webinar on the phone can hear the question in addition to the answer. So again, I'm with the Pennsylvania Health Law Project. For folks who aren't familiar with us, we're a statewide nonprofit law firm. And our work focuses really in some ways very narrowly on public health insurance programs. So by that we're talking about Medicaid, Medicare, and CHIP, the Children's Health Insurance Program. So our expertise is in those public health insurance programs, and so we focus on helping people who are eligible for those programs or who might already be on those programs that need assistance accessing care. So the focus of our work is really people who are low-income families, low-income people with disabilities, low-income seniors. One of the primary ways that we do our direct client work is through our helpline. People call our helpline. It's open Monday, Wednesday, Friday, 8 a.m. to 8 p.m. We unfortunately do not answer those calls live because we are such a small staff and we're helping people across the whole state. But people call in, leave the messages, and then one of 5 of us are on that helpline every Monday, Wednesday, Friday, get in the morning and start to pull those messages and start to return those calls and keep going for a day or 2. Sometimes it could take us into a 3rd day, depending on the volume, but generally not. And anybody can call the helpline. So it might be the individual having questions about their own situation, a family member, a social worker, whoever can call the helpline. And then from there, we can advise people. We can screen people for eligibility. Folks call us because they've become uninsured or have been uninsured. We can screen people for eligibility for Medicaid, help people understand things like, well, I had Medicaid, but now I have Medicare and Medicaid. What does all that mean? How does all that work? Help families understand if their kids might be eligible for CHIP versus Medicaid. What's the difference? What does all that mean? And I'm going to pause right here for a question in the room.
All right.
That's quite all right. Go ahead.
You may have already said this, and I just misunderstood. About how long are you averaging a call back if a client calls? Did you say it was like 3 days that you do?
Yeah, so the question is about the average in terms of, when we return calls. 3 days would be absolute max.
Okay.
General rule of thumb. Now, somebody will call me on it and say, I called you on Monday and you didn't call back till Friday. But yes, generally, and literally we're starting the calls, in the morning. So you could also be that person who left a message at 8 a.m. and we just returned your call at 9:30 this morning. Because we're really just returning those calls based on how they come in, just in the order. But the person on the helpline is very focused that day, on returning those helpline calls. So we really do make it a priority, absolutely, to return calls, quickly. And then the other piece around Medicaid in particular, not only the eligibility piece, but probably even more importantly and a bigger piece of what we do is helping people access services through Medicaid and helping people if they're denied services through Medicaid. People have appeal rights, and we can advise people through that appeal process if some prescription or some level of medication, some level of service, whether we're talking about for children or for adults, is prescribed and then Medicaid denies or the Medicaid managed care plan denies, the physical health plan, the behavioral health plan. We can advise people through that appeal process, and we can also represent people in those appeal process. And whether or not we represent somebody is usually based on, when you call us. So when you call us today and say there's an appeal on Monday, we're almost never going to be able to do that because there's just lots of time and work involved in preparing to represent somebody. And really depends on the merits of the case. So if we feel like somebody really has a good case and really should not have been denied a service or denied Medicaid eligibility, then we can actually represent people in those appeals. So that's kind of in a nutshell the direct client work that we do. And then from that direct client work is really what builds our policy advocacy, trainings and presentations that we do, information that's on our website that's everything from a 1- or 2-page fact sheet to a 40-page manual on, home and community-based waiver services. So lots of written information, and of course then we do things like today where we provide, both in-person trainings and webinars to folks, generally based on things that are topical and often based on how we're funded, because we're a nonprofit, so like other nonprofits, we write a lot of grants, and those grants, of course, have deliverables. So, which is part of what brought me here today, a grant from the Pennsylvania Developmental Disabilities Council. I always, like to tell folks with, when in doubt, if the question has to do with insurance, eligibility for insurance, public Medicaid in particular, and CHIP, or anything having to do with Medicaid, Medicare, and CHIP, call us. That's likely something we can help you with. So just, again, we're going to give a broad history of Medicaid at the federal and the state level, and then I'm going to turn it over to Erin to get into, more nuanced kind of information about, what's happening with Medicaid today, both at the federal and at the state level. So the program itself, Medicaid, was created in 1965 by the federal government. It is a federal, state-funded program. The rules, those stem from, federal legislation and from the Federal Center for Medicare and Medicaid Services. It is referred to as an entitlement program. Many times when I hear that expression used, it's used in relationship to the individual who then gets Medicaid. But really the first layer of the entitlement part of Medicaid being an entitlement program is that if a state chooses to have a Medicaid health insurance program, then they are entitled to federal dollars to support that program. That's the structure of Medicaid, and since 1965, that's always been the structure of Medicaid. And in addition to that funding guarantee that states have, and for every state that funding guarantee can look a little different. It's a state-federal match, and that match has to do with the population in a given state and the income level of people in a given state, and what might be happening even in any given state at any point in time or nationally. So that federal match can go up in times of recession or when a particular state's been hit by a disaster, a hurricane, something that really could impact it more than a month or two, then there could be adjustments in what the federal government pays towards that state's Medicaid program. Right now, Pennsylvania's match, I think, is around 51 cents that the feds pay, versus 49 cents that then Pennsylvania is responsible for, budgeting and having the dollars to pay maybe 49 cents on the dollar for every dollar of Medicaid, expense. So that's the financial and structure of the program, and that's how it's always, existed. When folks hear about, and we've certainly been hearing about it recently, over the last year or two, but it's not the first time that the concept of block granting Medicaid has been discussed, and it goes back many years where under different federal administrations that they've talked about, basically it would be a total restructuring of how Medicaid programs, the state Medicaid programs are funded, to move to something, called block grant funding that would, I think simply said, would be the federal government, giving the states, a lump sum of money, a block of money, and then the states having to figure out who they can cover with that money, what to do if the state had a disaster or just even a recession. Then states are dealing with basically kind of that same, block of dollars. So and we're not going to get into all the nuances of that in particular today, but when you hear people talk about, block grant funding to Medicaid, it would be a significant structural difference to how Medicaid was funded, and then what Medicaid could look like in any given state if we were then dealing with a block grant as opposed to the entitlement of that match that we have now and that we've had since 1965. Okay. So in order for states to receive those federal matching dollars, there are, as you could imagine, a whole lot of rules and obligations tied to the state. But one of them has to do with who the state provides Medicaid coverage to. So, for example, one of the mandates from the federal Centers for Medicare and Medicaid, if a state says yes, we want to be able to provide, health insurance, Medicaid health insurance to low-income people, that they have to provide to families, kids, aged in particular, aged, birth through 18, whose families have an income level of less than 138% of federal poverty. So any state with a Medicaid program, and every state has a Medicaid program, has to, at a minimum, in terms of the requirement from the federal level, provide Medicaid to kids who fall in, households with incomes, under that level. Same true for pregnant women. Same income limit. So if you're providing Medicaid, then you're providing it, again, entitled, guaranteed to, pregnant women whose income falls, within, under 138% of federal poverty level. Parents and families who get, who are eligible for cash assistance, then those parents have to also be guaranteed Medicaid. That cash assistance program is it's a very, very low amount and hasn't changed. It hasn't changed in the decades that I've been doing this work in terms of, a single person, well, they've cut that out altogether. A household of two gets $316 a month on cash assistance. This rule is saying that family eligible for cash assistance then has to also get Medicaid. That $316 hasn't changed in decades. And seniors and persons with disabilities who receive SSI, supplemental security income, those folks automatically get Medicaid, and that's tied to the federal rule that says they have to. And then, in addition to those mandated populations that the states have to cover, low-income pregnant women, low-income kids up to the age of 18, seniors, people with disabilities getting SSI, then states can also cover beyond those optional categories, and states can decide to cover people in those prior groups with income limits even higher than the 138%. So states have the option to do that. They don't have to. They have to, at the minimum, follow the federal rules. So in Pennsylvania, we do cover kids, and depending on the kid's age, the income limit is actually different. Younger the child, older the income limit for that child to qualify for Medicaid. And so all those things have to be approved at the federal level, but there is lots of flexibility within the state Medicaid program. There's this baseline that states have to meet if they're going to be taking those federal matching dollars. But then they can do, above and beyond that. And they can have, categories of people. And I often think about the MOD category, the medical assistance for workers with disabilities. When I started over 17 years ago with the Health Law Project, and I initially started, that category of Medicaid didn't exist. It was probably within maybe a year or so of starting my work at the Health Law Project that the state adopted this additional category. And again, it's always done with the approval of the federal government, but this is an optional category, one that we, from my perspective, thankfully still have, that covers people, as kind of as the name implies, medical assistance for workers with disabilities. People have to be age 16 to 64, both working and determined disabled, not necessarily by Social Security, and their income can be up to 250% of the federal poverty level. That's an example of an optional category of Medicaid, and one that Pennsylvania has and has had now for maybe 15, 16 years. I lost track of when we implemented. Okay. So that's just some of the broad, Medicaid at the federal level. At the state level, as I'm sure most folks know, Medicaid is the federal name. Pennsylvania calls their Medicaid program medical assistance. Not sure why. I think life would be simpler when health insurance is so complicated to begin with if everybody just called Medicaid, Medicaid. But again, I guess that's one of the options. States can call their Medicaid program whatever they want. So in medical assistance, in Pennsylvania we call it medical assistance, but also is referred to as Medicaid. So sometimes we'll talk to folks on the helpline and, in trying to, help with whatever their issue might be, I ask somebody if they have Medicaid, and they say, no, I have medical assistance. It's just how you know it. Same thing, the exact same thing, just what we happen to, call it. Most people have to apply for Medicaid, be determined eligible or not, entitled to a written notice, whether they're eligible or not, they're entitled to a written notice, and they have appeal rights if that notice says we, processed your application and we determined that you're ineligible. So with the exception of people, both kids and adults, who receive a Social Security benefit, SSI, Supplemental Security Income, that's a Social Security income benefit for people who are both low income and Social Security has determined meet the criteria of either a child or an adult with a disability. Those Pennsylvanians who get an SSI check, no matter the amount, because your SSI check could vary based on other factors, like who else is in your household. As long as you're receiving an SSI check, maybe it's $20 a month, maybe it's the max that's $7.75 a month, then that person getting that SSI, that SSI check is attached to, automatically gets medical assistance. So those folks don't ever have to even apply. They don't have to complete a Medicaid application, don't have to go on to Compass or a paper application, however they may apply to be determined. SSI automatically equals Medicaid/medical assistance. And then I'm going to pause a minute. I have a question in the room.
My son is disabled. He has not gotten SSI since 18. Every year I have to reapply for his medical Medicaid. Like he's got his secondary insurance, but I have to reapply all over again every year. What is the reason?
Yep, so the question in the room is from a woman whose son does have a disability, is not receiving SSI, does have Medicaid, that every year has to do an annual renewal. And that's correct. Sometimes I'm sure a hassle, but that's the law. That's how it's supposed to work. And that's true with the exception of the SSI, that's true for every category of medical assistance. Some categories even require a renewal every 6 months. Often, I think in the case of MAUD, the renewal is actually every 6 months. So the reason for that is just to, there's just not an assumption that once you're determined eligible, depending on how you're eligible, that you remain eligible indefinitely. So, they're reviewing again, in the case of somebody who could be a child who's getting medical assistance based on the disability, irregardless of family income, then sometimes what the county just needs to review, and doesn't always, but, may just be asking for besides updated income information, the state wants that information. The Pennsylvania legislature decided years ago they want to know who these kids are, even when their family's income doesn't count in determining eligibility. it's all about whether or not the child meets the definition of a child with a disability. And they may ask for updated medical records because, you know, again, a disability, depending, and we use disability broadly. I certainly do. You know, disability could mean, you know, just a significant or chronic health condition. So depending on what that health condition is that the county assistance office said, yes, this right now at this point in time meets the definition of, you know, a child with a disability or chronic condition, may or may not, you know, for that 10-year-old may or may not be the case any longer, you know, when that 10-year-old is 14. So that's all part of the annual renewal, but that's required.
No, he has to continue now. I guess this is me. So, and he goes to 21. When he hits 21, he still has to renew that every year the same way as I do now?
Yeah, so the question is, you know, what about, you know, when he hits 21? Actually, in the case of kids who get medical assistance because of their health condition or disability and get medical assistance under, that's a very specific category, sometimes referred to as the loophole category. It's technically, in terms of how it's coded in the Medicaid system, it's a PH95 category. A child who gets Medicaid under that loophole/PH95 category has to, that category just goes until that child hits 18. Then that child has to either apply for SSI under adult definition, because that's the determination Social Security has made, or be determined eligible for Medicaid under another category.
Now, he'll be doing this with 21. Like I talked to them recently, and they said he wouldn't be eligible for Social Security at 18 until 21.
Yeah, no, and I can talk to you about that, yeah.
I wouldn't apply till 21, and that's fine.
No, and I can talk to you more about that one-on-one afterwards. I'm glad to do that, because you're asking really great questions. And, you know, between Medicaid and Social Security, you know, the programs are so complicated. And when they're complicated, then it gets confusing and misinformation, all those kinds of things happen. So, yes, don't let me leave without you and I talking further about that. Okay. So there are lots of ways for people to be eligible for medical assistance. Very often, because it's such a complicated program, and there's a lot involved, except if you've got SSI and automatically have Medicaid, you know, the application process, there's so much involved that in the end, you know, people either know they're eligible and on Medicaid or they're not. Oftentimes, people have no idea how they qualify for Medicaid. And in many cases, it doesn't matter. You know, I've got Medicaid or my child has Medicaid, then it's more important about how do I access care or help my child access care. But the category, and the woman in the room who was just asking some questions, the category can be really important at some point in time, like when a child's getting Medicaid under that PH95 category and then turns 18. So it can matter how people qualify. But I guess the bigger picture is just, in order for any of us, adult, child, senior, whoever, to get Medicaid, we have to fit a category. And then within those categories, there are income limits. Some categories have resource limits. Some categories don't. So kind of lots of moving parts in eligibility for Medicaid. And even within the system itself, you know, for some categories, there's almost a bit of a hierarchy in terms of, you know, if a child or somebody fits one category, that's the category that they go in. So kids are a good example. If you know, if you apply for Medicaid for your child, the Medicaid system, it's why they need income information from the household. They need to know who all's in the household, because household size is also, you know, relevant to the household income limit. The Medicaid office is going to screen your child for eligibility first under the the child in a low-income household category. If the child, with or without a disability, they're not looking at that disability piece first. First, they're looking at age of the child, household size, household income, actually tied to things like, tax dependent or not, who, if anybody's claiming this child as a tax dependent. Let's see, lots of pieces that the system looks at. And if that child is eligible based on household size, household income, age of the child, then that's the category that the child is eligible for Medicaid, even if that child has a disability. And I'm going to stop again. I have a question in the room.
Okay, so in regards to the household income, you have a child who is receiving wage benefits from like an issue that happened at birth, and they determined since he cannot work, they're giving him the age benefit. Would that age benefit count as part of the income, or if they would be eligible, exercise Medicaid?
Yeah, so the question in the room is if a child is getting benefits based on, say, a disability or even, like an accident, something that then, something that then provides an income for the child, I think it could depend on the source of that income. But yes, it could be counted in determining that child's eligibility for medical assistance. Once somebody has Medicaid, depending again on whether it's an adult or a child, the actual benefits, the benefit package that adults on Medicaid get versus kids on Medicaid are different. The Medicaid benefit package for kids, and again, doesn't matter now once the child has Medicaid. If my child has Medicaid because of household size and low income, and Aaron's child has Medicaid because, not because of income, but because the child has a significant health issue or disability, doesn't matter now once they have Medicaid. Once each of our kids would have Medicaid, then the benefits available, physical health benefits, mental health, drug and alcohol benefits, prescription benefits, dental, vision, the package of benefits, what's covered for that child, mine or Aaron's under Medicaid, would be identical, based, of course, on what's medically needed. So, maybe my child ends up getting braces on their teeth and Aaron's child doesn't. That has to do with what got determined medically necessary or not. But in terms of that benefit package, what are all the things that are available to a kid on Medicaid is identical no matter how that child qualifies for Medicaid. And based on a federal law, EPSTD, Early Periodic Screening, Diagnosis, and Treatment, that federal law says kids on Medicaid get whatever is medically needed. So it really, really opens up and makes for a really, really robust benefit package for kids under Medicaid. Almost always better than any commercial health insurance covers for a child. So it's a very comprehensive, very robust. Kids get in-home services, in-home behavioral health services, again, when medically needed. In-home skilled nursing when needed, specialized daycare, medical daycare, in-home home health aid, really very generous benefit package for kids on Medicaid. Adults is certainly a good benefit package as well, but doesn't have quite the breadth that the kids' Medicaid benefit package does. But same is true for an adult. Once an adult qualifies for Medicaid, then the benefit package is the same. So it doesn't matter if, somebody's eligible for Medicaid because they're a pregnant woman in a low-income household versus an adult who's low income gets Medicaid versus a senior who's low income who gets Medicaid. The benefit packages for those adults is the same. So then once folks have Medicaid and have, again, for adults, a really good benefit package for kids, even better. Then once somebody has Medicaid, how do they access the services? How do they get care with Medicaid? Well, there's really three what's referred to as delivery systems currently. Well, three not through the whole state. Three currently in southwestern Pennsylvania. Three ways people get their services once they have Medicaid. The first way, and it's the smallest percentage of people across Pennsylvania that get Medicaid this way, is what's called the fee-for-service system, or using just your access card. So people who have, and for those of you who have been around, a lot of young folks in this room, but around as long as I have been, that used to be the only way people accessed care with Medicaid. People just had an access card. You were eligible, you weren't. If you're eligible, then you get an access card, and in order to get whatever services you need covered through that access card, you had to find a doctor or provider, a medical provider who took your access card. That's the fee-for-service system. That's, more than 20, 25 years ago, is the only system Pennsylvania Medicaid had. Then Pennsylvania moved, into a managed care system. So, and that system the state calls the Health Choices Program. That's the state's Medicaid managed care system, where the state contracts, and depending on where you are in the state, it's a different number of managed care plans, and they could even be, they're different managed care plans themselves. So the state contracts with Medicaid managed care plans. The state puts out a bid. Any number of managed care plans say, I want to do that. I want to be a Medicaid managed care plan. State reviews all those bids and decides on, out of the 10 insurance companies perhaps that responded to the bid, the state says these are the 3 or 4, in some parts of the state 5 managed care plans that people on Medicaid will have to choose from. That's the way most people have Medicaid, and then beginning January 1st of this year, the state has created a new delivery system, and some of you perhaps have heard me or others do a presentation on what the state's calling community health choices. That's a new Medicaid managed care system, and we'll talk a little bit more about that. And within the managed care system in Pennsylvania, and this has been the case since the beginning of Medicaid managed care in Pennsylvania, there are physical health plans and behavioral health plans. Some people refer to it as the carve-out in terms of the behavioral health piece was, carved out from the rest of all the Medicaid benefits, so that when somebody's on Medicaid, for example, in Allegheny County, and they're in the health choices system, or for that matter, in the community health choices system, they have a choice of physical health managed care plans when they have Medicaid. Then they also have a behavioral health plan. They don't have a choice about their behavioral health plan. That's determined by each individual county. So, for example, in Allegheny County, that behavioral health plan is community care behavioral health. If I lived in neighboring Armstrong County, my behavioral health plan isn't community care behavioral health. It's value behavioral health. So your behavioral health plan is determined based on the county that you live in. Your physical health plan, when you're in health choices, you have a choice. It's part of why the state calls health choices, and why they also call community health choices, because there is choice in there, and that choice has to do with having several physical health managed care plans to choose from. And I feel like I should have put this slide before now, but I'm looking at it. In terms of just, again, broad criteria to be eligible for Medicaid, the person has to be a Pennsylvania resident. What does that mean? It means I have to be here with the intent to stay. I'm not visiting. I'm not here just for a summer with my grandmother as a 10-year-old. I have to be here with the intent to stay. Beyond that, there's no time frame that I have to be in Pennsylvania before I can be eligible for Medicaid. And we have a question in the room.
This kind of relates to what, this is about CHIP. If you have a child who is on CHIP, which covers through age 19, they go away to their first year of college in the state. Does it cover medical emergencies out of state? I know that some of the Medicaid programs do, some of them do not. I don't know about Pennsylvania.
So are you asking, so there's a question, are you asking about CHIP or are you asking about Medicaid? Because they're two different programs, they're two different insurances. CHIP only goes until age 19, not through 19.
No, yeah, that's what I mean, it goes until age.
Right.
It goes up until age.
Right, right. So in terms of, well, and really probably in the case of Medicaid or CHIP, if somebody, child or not, has Medicaid or CHIP in Pennsylvania, and let's say in the case the question was specific to, you know, a 19-year-old who now goes to college and goes to college out of state, you know, do they have access to, you know, to health care out of state? An emergency situation is perhaps the only example where the services would be covered. Otherwise, probably not likely. So a kid who's in college would, you know, wants to have a, you know, a routine checkup with the doctor or even the dentist, for the most part, needs to try to make that happen when they're back in Pennsylvania with the providers in the network of their CHIP health insurance plan or their Medicaid health insurance plan.
Okay.
As we talked about, fit a category, have to fit the income and limits, and then people have to be either a U.S. citizen or what's considered a qualified immigrant or somebody who's lawfully present. And those terms are different depending on whether we're talking about a child or a pregnant woman or somebody else. So that piece is important in terms of the criteria. So in terms of these categories of Medicaid, the Affordable Care Act, when it was passed, had to do in large part about helping people who, adults in particular, who were uninsured gain access to health insurance. But part of the law in the Affordable Care Act also expanded Medicaid for every state. Initially, it expanded Medicaid, required every state to expand their Medicaid programs. I talked earlier about that mandatory categories and income limits of Medicaid. This expansion kind of added a mandatory category. Many governors appealed and fought that decision all the way to the Supreme Court and said the federal government shouldn't be able in the Medicaid program to require this expansion category. Supreme Court agreed that it had to be optional for states. And so one by one, each state then had to choose, will they expand their Medicaid program to adults age 19 through 64 whose income is less than 138% of federal poverty. Initially, we did not expand Medicaid in Pennsylvania when it was first available under the Affordable Care Act. Eventually, Pennsylvania did. So we now have that expansion category that has added about 750,000 people who have adults in Pennsylvania who now have insurance that didn't have it prior to, you know, to the law that allowed the Affordable Care Act that allowed states to do that. And
will that change for 2019?
so the question is the Medicaid expansion category going to change for 2019? It could. It could. I mean, there's nothing right now saying that's going to happen. We, at the federal level, and Aaron will likely touch on some of this, at the federal level, under the Trump administration, there's lots of talk and you know, proposed changes, many of which last year the Trump administration tried to do. They tried to make a lot of changes to both the Affordable Care Act, repeal and replace. I'm sure any of us had to be under a rock to at least not hear something's going on with the Affordable Care Act, and appeal and replace. Within many of those bills that occurred over the last year, none of which got passed, there were proposed changes to both the Affordable Care Act, which some people refer to as Obamacare, as well as Medicaid. So we know prior to President Trump, from President Trump the candidate, as well as now President Trump the president, that he's, he has a very different perspective on Medicaid than the prior administration did. So what's that going to mean? We're not sure. Aaron's going to probably talk to us about some of the possible impacts. So expanding Medicaid, again, helped a lot of people, and we expanded Medicaid in the midst of a national opioid epidemic, where unfortunately Pennsylvania kind of is right up there at the top of people dying from opioid addiction, both pills and heroin. So with the expansion of Medicaid, of that, what's now I think about 790,000 new adults on Medicaid since we expanded in the last couple of years. The last numbers I saw, I think, were close to about 130,000 of those 790,000 adults, once getting Medicaid, have accessed treatment specifically for an opioid use disorder. We're not even talking about all the other addictions, the substances people can become addicted to. It's a huge number. But provided treatment to lots of folks. So who are the folks on Medicaid? As of the February numbers that I found from the Department of Human Services, 2.9 million people in Pennsylvania on Medicaid. I think our population is 13 million or so. So it's a very significant health insurance program for, really a large percentage-wise of the, of the whole population of Pennsylvania. And then just in terms of, I always think sometimes these numbers are interesting, who is it that, who are we covering in Medicaid in Pennsylvania, and what are the costs associated with it? So, in terms of elderly and disabled, if you look just at those two, they make up 30% of the Medicaid population in Pennsylvania right now, with costing about 63% of expenditures. That's including folks in those, both the elderly or disabled category. Medicaid pays for nursing homes for low-income, low-resources people. And so as we can all imagine, nursing home care being, the most expensive level of care, especially because it tends to be ongoing, if not for months, years. So, a big chunk of Medicaid dollars are in home and community-based waiver programs for both kids and adults, nursing homes. So even though those folks make up 30% of the population, 63% of the Medicaid expenditures are on, are on seniors and people with disabilities. Kids and families make up 43% of Medicaid population, but only 17% of the spending. So, and then you see the adults in the Medicaid expansion category, the percentage, and the cost to the state's overall Medicaid program. So we touched earlier on community health choices and the fact that once people have Medicaid, then there are 3 different delivery systems in terms of how they get care once they have Medicaid. That's fee-for-service system, the health choices, the Medicaid managed care system called Health Choices, and now beginning January of this year in Southwest PA, right now only, 14 Southwest PA counties, we now have a new initiative that the state has been embarking on, has now in effect in Southwest Pennsylvania, called Community Health Choices. Those folks, and sometimes it gets confusing, like people think those Health Choices managed care plans are gone now because we have Community Health Choices. They're not gone. There used to be 2 ways people could, once they had Medicaid, then they get care. Now, depending on who you are, where you live in the state, and what your specific circumstances are, you might be going to see doctors because and accessing care because you've got Medicaid with just your access card, versus somebody who's in the Medicaid managed care system health choices versus now a new group of individuals, people who have both Medicare and Medicaid. And again, for right now, this is just 14 Southwest PA counties. Next January, Community Health Choices moves into the 5 Southeast counties, Philadelphia and surrounding. January of 2020, all the rest of the state, often referred to as that T-bone part of the state, all the rest of those counties will implement Community Health Choices. I'm going to stop again for a question in the room.
Now, you were saying about the first one, was it like the access card?
Mm-hmm.
You said you had like limited doctors and stuff, so the other ones have that too, where you, I know that I'm wondering if that's what I really have, because I've got a list of doctors that only cover like the Medicaid and have a secondary. Are they all like that, where you have to go to certain doctors to qualify?
Yeah, so the question is, no matter.
Whether it was just certain programs and then it
Right.
expands more if you have a different choice.
Right. The question is, so depending on, how I'm accessing my Medicaid services, is it just with the access card, or am I in the Health Choices Managed Care or the Community Health Choices Managed Care? Does that make a difference in terms of what providers any individual can see? Yes. Yes. And in that way, it really kind of works like just about every other health insurance, that anybody could have. And again, it might be different, somebody has an HMO versus a PPO, so maybe I can see more people, or maybe I pay more if I go out of network. So Medicaid works similarly. If I've got an access card, I have to make sure I'm accessing a provider that takes specifically just the access card. If I'm in, the Health Choices program or the Community Health Choices program, and again, depending on if I'm trying to access a physical health service like a cardiologist versus a behavioral health service like a psychiatrist, I have to be paying attention to all of that. I don't want to just call and make an appointment with a psychiatrist and then get to the door and find out, well, you've got Medicaid in Allegheny County, so your coverage is with community care behavioral health, and this psychiatrist doesn't take community care behavioral health.
I run into that a lot, but I didn't know whether there were other choices. I just had that one, but they were all the same.
Yeah, and we can.
They have to all follow that guideline that you have to just go to doctors and take them.
Yes, yes. Generally speaking, there are always those exceptions, and if you're in a managed care plan and your managed care plan cannot find any doctor who's can treat you, then there's some other possibilities, like, well, then that managed care plan has to go out of network and help you find a doctor out of network. But by and large, you're working with the network. In the case of managed care plans, the best way to do that when you're not sure is just call the managed care plan, or go on their website, or just call that doctor you want to go see and say, my child has Medicaid Gateway. Does Dr. So-and-so take Medicaid Gateway? So community health choices, who are the folks impacted by that? People with both Medicare and Medicaid. In Pennsylvania, people who are in nursing homes paid for by Medicaid become a part of the Community Health Choices Managed Care System, and people who are receiving home and community-based waiver services, specifically the waiver service programs that are a part of the Office of Long-Term Living. In the rollout of Community Health Choices, again, the state created a new managed care system, put out a bid to managed care companies far and wide, whoever are interested and responded, to say the state now wants to contract with managed care plans to provide Medicaid for these groups of folks. They're going to be 450,000, maybe more, across the state. Once all of Community Health Choices is rolled out, we could probably be looking about 500,000 Pennsylvanians who will be in this Medicaid managed care system. The state ultimately contracted with 3 managed care plans who have now become the Community Health Choices managed care plans. AmeriHealth Caritas, Pennsylvania Health and Wellness, and UPMC Community Health Choices. So folks now in Southwest PA who are in, hoping not making people crazy back and forth, who fall into one of these categories, prior to Community Health Choices in Southwest PA, had Medicaid, had it, in either the fee-for-service system or in the Health Choices system. Now these folks are a part of the Community Health Choices system and are enrolled in one of those 3 plans. And again, under Community Health Choices, 3 plans available. People can change their plan anytime throughout the year, change back and forth if for whatever reason need be. That's a part of the choice in Community Health Choices. Okay. So, and I already kind of touched on this, rolling out in phases. It's here and alive and well in Southwest PA, and SAN and the Health Law Project have been knee-deep in implementation of this new Medicaid managed care system and what it's meant for people and how it's changed how they access care. It's been a big undertaking for the state and a big change for what in Southwest PA has been about 85,000 individuals impacted by this new way for people to get Medicaid. So, and just I think before we move into Aaron's presentation, when I think about Medicaid at the state level, and I think we touched on this earlier, that the history of Medicaid, the funding of Medicaid, all written, of course, into law. But laws, of course, can be amended, laws can be abolished, laws can be changed. And so how that looks, how that plays out in terms of Medicaid at the federal and the state level is almost always tied to who's in power at the federal level and at the state level, and whether or not you have a federal administration who is highly supportive of Medicaid versus an administration who looks at Medicaid in a very different lens or focuses more on the costs of Medicaid, perhaps, versus the benefits of Medicaid. And same is true at the state level. And I think a good example of that was earlier when I said the Affordable Care Act allowed for expansion of Medicaid to every state's Medicaid program. Under the Tom Corbett's governor as Pennsylvania administration, initially we did not expand, because that was, the philosophical thinking of that, of that governor. Ultimately, towards the end of his tenure, he did expand Medicaid. Tom Wolf campaigned on being very supportive of Medicaid, on the expansion of Medicaid, and on simplifying the expansion of Medicaid, and which he did. You were either eligible or you aren't. And so, again, that ultimately put, about 790,000 adults, uninsured adults, on who have insurance now because Pennsylvania expanded Medicaid. Medicaid continues to be a priority of this governor and this administration. Secretary Teresa Miller is fairly new to the position of the Secretary of the Department of Human Services. The Department of Human Services is responsible for the state's Medicaid program. So very committed to Medicaid expansion. A question in the room earlier was, is Medicaid's expansion still going to be here for perhaps come 2019? Again, those are unknowns in some ways. Again, no reason to think it's right now. Nobody has said it's going away in 2019. But between activity at the federal level and then, of course, we have a governor's election this year. So, and Governor Wolf is running for governor again. So lots of moving parts. And again, I want to try to watch time because I want Aaron to get into the moving parts.
I want to ask you if all these changes are going to happen in 2019, will you have another meeting toward the end?
Yeah, so the question is if if changes are happening or we know they're going to happen, like in the case of community health choices. We worked and others worked very closely with the state as they were rolling out community health choices, and, we and others did a lot of training, in-person webinars, et cetera. So, yes, certainly from the Health Law Project's perspective, again, always to the extent of our resources and, funding and how many people we have, if changes are coming to Medicaid. And we have a newsletter that if folks are not getting and would like to, please just let me know. Just need your name and email, because our newsletter is always letting people know about even those kinds of things that are not happening yet, but perhaps could be, again, both at the state level and at the federal level. So, Governor, this governor is supportive of Medicaid expansion, supportive of Medicaid funded as it is now and has been since '65 as an entitlement program, is not in favor of a Medicaid block grant, and wrote lots of letters to the Trump administration last year saying, don't block grant Medicaid. And as you can imagine, his secretary, Teresa Miller of the Department of Human Services, supports that as well. The governor's February proposed budget proposed a consolidation at the state level of the state's Department of Human Services and the Department of Health. Pennsylvania legislature has to, it's part of his budget. Pennsylvania legislature has to agree to that or not. If that happens, if the legislature agrees, governor's going to sign off on that, I would certainly imagine, because he's the one who proposed it. And so right now we have a state Department of Health, we have a state Department of Human Services. Governor's proposing they become one department, within the state. The governor has had a very strong commitment since, again, I think his days of, campaigning for governor. This governor is very focused on the destruction of the opioid epidemic, the lives lost, the families destroyed, and has done a lot of things, has taken really a very multi-pronged approach to trying to fight the opioid epidemic, trying to get treatment to people who are battling these addictions, and that's included certainly the use of Medicaid dollars, has created centers of excellence across the state that are focused on specifically helping people, engage people in treatment, people who are battling an opioid use disorder. This governor and the secretary in particular, again, she's fairly new, but several times I've either heard or read, generally reading, about, her focus on the social determinants of health. Not a phrase I think she's coined necessarily, but one that I hear her use where, she really takes what we in the social work field, I think, would say, a very broad, holistic view of, individuals, families, communities, and how, one piece of those things affects the other. So she's very focused on things like, our health care isn't just about our health care. It's really very, very tied to how healthy we are or not, how much access we have to health care is also tied to things like our housing and access to food and healthy food. So employment, absolutely. And this administration also, and again, I think speaking, trying at least putting their money where their mouth is, very focused on expanding services to people with disabilities of all types, certainly individuals with intellectual disabilities, and with every budget the governor has proposed, sometimes approved as proposed, sometimes not by the legislature, that has continued to propose increased funding for people with disabilities, and very focused on people living in the community as independently and as wholly as well as they can, and people not in institutions and not in congregate settings and not in their homes. And then this is just some specifics that is in the governor's proposed budget. And again, I think, some of this I've already touched on, and, I mean, there's obviously a whole lot of things in the governor's budget that has to do with, you know, everything the governor's responsible for, education and lots of other areas. But, you know, these are just some of the priorities. I just pulled this language directly out of the governor's proposed budget. If passed timely, Pennsylvania tends to have a challenge in doing that, but when passed timely, a budget should be passed and signed off by the governor by June 30th of any given year. So we're certainly in that. The governor's budget's been proposed, and we're in that period now where, you know, the legislature and he and others are, you know, working on where are we landing in terms of funding a budget and what the funding priorities will be. But that's what's in the governor's budget. Okay, I'm gonna stop even if we don't have questions, because I want to make sure Aaron has time to cover. I certainly, and I imagine Aaron as well, can be here beyond, you know, our time. But I want to go ahead and move on to Aaron. There you go, Aaron. There's your.
All right. Well, let's give you a hand for that excellent overview. Thank you. And if folks want to get up and, like, stretch, I know sometimes it's hard to sit for 2 hours, so I won't be offended if you need to get up and move around. That's totally fine. It's wonderful to work so closely with Janice. She's really a healthcare hero, and we refer a lot of people to the Health Law Project for help, especially with appeals and denials, because that is such a difficult process. Raise your hand if you've ever had to deal with a Medicaid denial or file an appeal to get a service or help someone through that. Has anyone done that? Yeah, so very, very hard. And not only do you need an advocate in your corner, often you need someone with that kind of legal expertise. So we're also really happy to be here with Achieva. Achieva has been a great partner in our work to protect and expand Medicaid throughout the Medicaid expansion campaign. And I'm going to talk about a specific initiative that's happening right now to improve access to oral health care under Medicaid and restore some of the cuts that were made back in 2011. So I leapt right into it without telling you who I am. My name is Erin Neinhauser. I'm the Consumer Engagement Manager with the Pennsylvania Health Access Network. PAN is a statewide consumer-led, consumer-focused organization that works to protect and expand access to health care. So we work on both state and federal policy issues, and this is how folks can get a hold of me. That's my direct cell phone, and I hope people will use it. We're often a good first call for help thinking through how to best address the situation, whether it's a problem, someone who's applying for services for the first time, or rapid response around needing to defend Medicaid from cuts or harmful changes either at the state level or in Congress. This is just a little bit about our work and our model. I won't go through everything, but we have an enrollment program that operates statewide as part of a consortium funded locally by Consumer Health Coalition. So we are one of the federally funded navigator organizations, and we can help people apply for health insurance throughout the year for Medicaid and CHIP. And during Marketplace open enrollment, we do a ton of work. Folks stay up. Probably someone's available almost 18 hours a day to help people sign up during Affordable Care Act open enrollment. And what our direct work with consumers, helping them access health insurance and then access services, informs our advocacy, because we learn about the problems and the barriers people face, not only getting their coverage and, you know, dealing with the county assistance offices or fighting with healthcare.gov, or often it's a documentation issue. It's really hard to just get all your paperwork together, get it into the right place on time. So troubleshooting all of those issues and helping people learn how to use health insurance, often if folks haven't had it for a number of years, that informs the policy advocacy that we do and our organizing. So we hold a lot of events out in the community. Specifically, I've been working a lot on the transition to community health choices. So we've been going to libraries and senior centers and housing high-rises and everywhere we can to talk to people one-on-one, because we know that these health system issues are very complex, and you know, nothing beats that face-to-face interaction to sit down and take the time, you know, to help people understand how these systems work, how to access them, and how to maintain health insurance. And that's, again, why CHLP's work is so valuable. So I wanted to start off with a little exercise here. and take a minute. So I'm hoping folks will do this. I wanted to think about the future of Medicaid and share some updates on what's happening. But before we do that, I wanted to ask two questions. What do we like about Medicaid now? What are the things that work well? And what are the ways in which Medicaid could work better? So I want to give people about a minute. I'll look for thumbs up when folks are done. But just take a minute and write down your thoughts on these questions, and I'm going to ask for a few volunteers to share your ideas. And folks that are on the webinar, feel free to participate too. And hopefully, Greg, if there's anyone that shares their thoughts, you can let us know. All right, I'm seeing some pencils down. So let me ask for a volunteer to share their thoughts on this first question. What do we like about how Medicaid works now, or what it covers, or anything about Medicaid? What do we like about Medicaid? Hopefully, there's something that we like about Medicaid. Go ahead.
I appreciate that it covers behavioral health services that aren't typically covered by the commercial plan.
Yes. Oh, and repeat it for folks on the phone. We appreciate that Medicaid covers behavioral health services that aren't typically covered under commercial or private health plans. That's a really excellent point. Anything else that we like about Medicaid?
A lot of the services you do not need to get pre-authorization for. There's not, they're constantly running back and forth between doctors trying to figure out who I need a referral from and all of that. That makes life a lot easier.
Great. And just to repeat that, in Medicaid, there's often less prior authorization hoops that people have to jump through to get needed services, and fewer referrals that people have to get to obtain those services. Excellent. One more?
When my son was in the hospital for 5 months, covered everything. And I didn't have to worry about it because bill. I mean, they sent a bill for a couple $1,000, but it ended up getting covered by Medicaid.
Excellent.
And that was a very costly bill, cost $100,000.
Wow. Wow.
She was there for 5 months.
5 months. Wow. So someone just shared a story of her husband being in the hospital for 5 months.
Yeah, my
Your son was in the hospital for 5 months. The total bill was $500,000, and Medicaid covered all of it.
Well, no, Medicaid, the Gateway covered, and then Medicaid.
It picked up the rest, but you didn't see any of that burden on yourself. That's an excellent point, because Medicaid really provides financial security for everyone that it covers. So much more than private health insurance that can have significant out-of-pocket costs for things like a hospitalization or even an emergency room visit. So that's great. Thank you for sharing that. Now, the second question, there's probably going to be more responses to this. In what ways could Medicaid work better or do more to support the populations that it covers?
I believe they should expand better on the doctor list, especially with having a nonverbal special needs child. A lot of the doctors on that list are not able to, they don't react really well to special needs. It makes you really limited to like dentist appointments and things like that. They don't want to know dates and stuff. I think you get people that more specialize in special needs and add to that list, then you can get, a little better services as far as those where you have sedations and clean your teeth.
Thank you for sharing that. So for folks on the phone, the suggestion was for Medicaid to have bigger networks within the different managed care plans, especially to make more specialty care available to people with disabilities, especially around dental care, people who might be nonverbal. This is a big priority, and this is an issue that we want to work on a statewide level, is understanding what access to specialty providers is like, especially for people with disabilities, and particularly in rural areas where there tend to be less providers in general. And I think, you know, just to add on to that, one of the challenges of building provider networks is that the reimbursement rates are often lower than for Medicare, for private health insurance. So boosting some of those reimbursement rates could help attract more providers into the system. Thank you for sharing that. I'm going to see if anyone else, and I'll come back to you. So what else could Medicaid do to work better? Any other ideas?
Okay, as far as private psychiatrists, there isn't any out there that'll take down insurance. They won't even take Gateway. I've called Gateway, Medicare insurance, a number of times. They have one or two psychiatrists that will even take their card, let alone access picking up the rest.
So again, the concern is a limited number of providers, but this time for behavioral health care, a limited number of psychiatrists, and the inability to go to a private psychiatrist and have Medicaid pay for that. Thank you. That's a really important point. Anyone else? So we have a full three.
I think in the sign-up process, when there are denials, there's limited information about what basis that decision is made on. And I think there's a big deterrent for in the sign-up process. People don't, they think they're denied and they don't understand what the appeal process is because it's just that lack of information and the way it's worded. So, people stop trying to need it.
Absolutely. Yeah, thank you. That's another excellent point, and we've seen that a lot in our enrollment work. The feedback was that there's not, when people are denied, when they apply for Medicaid, there's not enough information on that denial notice that helps people understand the reasons they were denied or how to file an appeal. It's an intimidating process, and I would add that, often people, what we found in our grassroots work is that people are often kind of cynical or skeptical that they can be helped after they've gone without health insurance for so many years. And what Janice mentioned about not having Medicaid expansion in the first year that it was available, the Affordable Care Act allowed states to expand Medicaid as early as 2014, and our governor at that time chose not to do it. And so the really terrible situation it created was that people who needed the help the most were told that they don't make enough money to get help, which is just a crazy thing to hear. So I just, in February, signed up someone who fell into that gap in 2014, who just thought that, none of these programs would help her. So here we are 8 years later, and, finally she signed up. So I think that's a really important point, making the enrollment process easier in general, having someone to support you through it. Thank you. So these are really good ideas, and, we're going to talk about areas with Medicaid where we need to play defense and defend against harmful changes that we know are coming down the pipeline. But I wanted to have this discussion to think about areas for offense and ways that all of us as advocates, as consumers, as family members and caregivers can build a proactive agenda to change the conversation about what Medicaid should do, how it should be protected, how it should be funded. Because if we're always reacting to things, we're not able to project that kind of forward-thinking vision that could really strengthen the program for those it serves. So we spent a lot of time at the Pennsylvania Health Access Network thinking through what a proactive healthcare agenda would look like at the state level. So we identified these 4 areas focused on, and some of these relate to, some of these relate to private health insurance, but most also relate to Medicaid as well. So affordability, bringing down the cost of health insurance and prescription drugs through increasing transparency and enacting measures to stabilize the individual health insurance market so that we're not seeing the kind of rate spikes we saw in the last open enrollment period. Coverage that means something, so that whether or not you have Marketplace or Medicaid insurance, you can take your card and see a provider in your community and get the services you need without having to jump through so many hoops or being surprised that you're in a plan that doesn't cover something you thought that it should. Janice talked about this, and this is a really important area, especially to think about over the next couple years, and that's how can we provide more support for people outside the doctor's office, because health is about much more than what happens inside a medical setting. It's affected by whether or not you have connections in the community, whether or not you have access to healthy food and a safe place to exercise, whether or not you have a safe, stable place to live that's cool in the summer and warm in the winter. So looking at ways to help move some of the money from our medical system into a social support system so that people don't have to fall and break a hip and spend, a month in the hospital and then 2 months in the nursing home because they could have simply had a stair glide installed or grab bars put in the house. So these are some of the conversations that are happening now that are important not only because they allow people to live independently and be safe, they also save money. So this is a way for us to have a different conversation about how to save money in Medicaid that isn't about kicking people off a program or cutting benefits, which unfortunately is what we've seen a lot of, especially right now in Congress at the federal level and in a certain contingent of our state legislature. And also telling the real story of Medicaid. Part of the reason, so one of the things that Senator Casey said recently when we had the opportunity to meet with him to share stories of people who are covered by Medicaid, actually Nancy Murray was there and talked about the importance of Medicaid for families whose children have disabilities. We had other people there who get waiver services to live independently in the community. And one of the things Senator Casey said that really stuck with me is that throughout the last year in 2017, through the pretty toxic repeal fight, he said we found out that Medicaid is an us program, not a them program. And for a lot of years, people who were opposed to Medicaid really tried to create and play up harmful stereotypes about, what's the face of a Medicaid recipient. But as Janice went through, the biggest group of Medicaid recipients in Pennsylvania is children. And most funding supports older adults and people with disabilities. So telling the real story of Medicaid and how it works can help change the conversation and shift things away from, these sort of punitive, stereotype-driven policies like work requirements, which we're going to talk about right now. So there are two state House bills, House Bills 2024 and 2138, which would force individuals and families who rely on Medicaid to document that they are employed or performing certain job search and job training activities in order to keep their coverage. And if they don't comply with these new paperwork requirements, they could be shut out from Medicaid from 3 months, 6 months, 9 months, or even a lifetime ban if they get, so many strikes, essentially. So I'm going to go through these bills in a little more details here. So both bills, as I said, implement a work requirement and lockout periods. They apply to all non-disabled working-age adults who are not pregnant or in school. And they would require people to work 20 hours a week or complete a job search that has to be verified and approved by the Department of Human Services, and then complete 12 job training activities a month. So how we've been talking about work requirements, because there's a couple things going on here. Medicaid now is almost as popular as Medicare nationally. So Medicaid has seen a significant jump in its popularity as more people, almost 800,000 more people in Pennsylvania got covered through Medicaid expansion. But across the country, this is happening. More folks are interacting with the Medicaid system. They're seeing how great it is to not have that fear of financial ruin if someone in the family has to have an extended hospital stay, how easy it makes regular preventive care. I was on Medicaid for a time to work on a startup project. I would have never been able to leave a job with health insurance to have the freedom to do that. I loved having Medicaid. I was really sorry to give it up and go back to private health insurance because now our costs are a lot higher. So Medicaid has high public support because more people are interacting with the system, but unfortunately, so does the idea of work requirements. And I think this kind of goes back to, this punitive streak that has taken hold in our politics, that we want to look for ways to blame and punish other people, and that's really unfortunate. So how we talk about Medicaid work requirements, obviously, you know, if people want to work and they're able to work, we should put supports in place that make it possible for them to do that. But this is not about doing that. This is really a backdoor way of trying to cut the program, and we can see an example of this in Kentucky. These are Kentucky's own estimates about what their new state's work requirements will result in, about 100,000 people losing coverage over the next 5 years. So that's about 15% of Kentucky's Medicaid population that could lose coverage due to burdensome new work requirements that force people to jump through hoops, complete all kinds of new paperwork, check in with the state all the time just to keep their health insurance. So in addition to the lockout periods, or in addition to the work requirements, there are lockout periods for people who don't comply, who could lose their coverage for 3, 6, or 9 months. There would be biannual redeterminations. So Janice talked about in the MOD program, folks having to prove their eligibility every 6 months for their disability and their income. This would institute those biannual redeterminations for all people that are non-disabled and of working age. Currently, those renewals are annual. They're once a year. Eligibility bans would come into play for anyone who fails to comply with the biannual redeterminations or exceeds the 3 lockout periods. So right now, so House Bill 2024 hasn't moved. 2138 just moved this week. It was passed out of the House Health Committee on a party line vote, and now it's moved on to the Appropriations Committee in the House, so it would have to pass there and then go to the full floor of the House of Representatives, or the state legislative house. There's no movement on the bill in the Senate, although once it passes in the House, it could be taken up, but we're not clear on whether or not that would happen or what the timeline is for that. And Governor Wolf has stated his opposition to work requirements. He could and has said in the past that he would veto work requirements, but this would be a politically difficult thing for him to do, and I think, as Janice said, it's a gubernatorial election year, so this is why it's so important to talk about, help people understand the impact of work requirements and why they're bad for Pennsylvania, because we do have a governor that we could count on to veto work requirements, but it's going to be a decision that he takes heat for. So being able to point to grassroots opposition to work requirements can help him make that case. So,
I have a question.
Oh, yes.
I have a friend that has a daughter that doesn't have health insurance because she doesn't want to tell anybody she's bipolar, but yet she was in the hospital and they classified her as bipolar. So what is she going to do? I mean, she doesn't want to, you know, say that she's bipolar or go get an attorney and get Social Security or anything.
So she could, that's a great question, and so she doesn't have health insurance right now. She could sign up for Medicaid expansion and she doesn't have to disclose any of her health history, because under the Medicaid expansion rules that Janice had up earlier, for a single person, you can make around $16,000 for the year. That could be your yearly income or less, and you can qualify. They don't look at your assets, and you don't have to report anything about your medical conditions or health history. If she wanted to get additional services through like a waiver program, then she would have to share that information. But just to get health insurance and access to behavioral health care and have that protection, she could sign up for Medicaid expansion. So she, the first one on this on the handout here. Yes, call me. Yeah. And we can connect with our navigators.
All right, thank you.
Definitely. And they can help people over the phone. And there's an online application through Compass. Actually, Compass just got a redesign. Has anyone seen the new Compass? Yeah, pretty exciting, huh? Looks pretty.
Well, what if she can't? What if she doesn't want to do it? But her mother wants her to help.
If she doesn't want to do it, ultimately, you know, nobody can force her to do it, but she could talk to a navigator. I could talk to her and just encourage her about the benefits and try to reassure about those fears of having to disclose a diagnosis. That's pretty much all the best we could do.
All right, thanks.
You're welcome.
I was just curious if there's been any updates on Compass for some annual reporting forms to be completed that way. I know that on the Compass mobile app, the semi-annuals can be completed that way, but in the past they could only be completed via the paper form, which they could do the renewal on Compass, but they could never do the semi-annual.
Is that a recent update that you're aware of?
Not that I'm aware of.
Okay, yeah. Just curious.
Okay.
I haven't received or seen any information about it yet. I was just curious if there's something with new updates that just happened.
So semi-annual
Semi-annual being
through the
available
through the web
on Compass.
through Compass.
Yeah.
Okay, I'll follow up on that. That would be a great benefit to have. Make it a lot easier. So we'll go to the next here. This is one of the infographics that we put out. Would definitely encourage everyone to look at follow our Facebook page. We're at Pennsylvania Health Access Network. We share action alerts and infographics like this. This tells a story, visually of why work requirements are bad and harmful for Pennsylvania families, how they make it harder for people to keep their coverage, and how precious state resources would be wasted setting up this new bureaucracy to solve a problem that really doesn't exist. Already, 3 out of 4 people that are enrolled in Medicaid expansion have at least one full-time worker in the house. 58% of newly eligible people in Medicaid are working, and even 18% of people who are blind or disabled are working. So we have pretty high levels of people that are covered by Medicaid and working already. And those who can't, or those who don't, have very good reasons. They're taking care of a family member. They have a serious chronic health condition. There are a lot of really good reasons that people, frankly, shouldn't have to justify for why they can't work, or they can't work to the degree that the state wants them to satisfy these new work requirements. All right, so nationally, federal law defines Medicaid's purpose as furnishing medical assistance on behalf of people whose income and resources are insufficient to meet the cost of necessary medical services. So it doesn't say anything about having to work to qualify. Medicaid is a health insurance program, not a job training program. We have lots of job training and support programs that, could be expanded, could be better funded, put in more communities, but that's not the purpose of Medicaid. But unfortunately, what we saw from the Trump administration is giving approval to states to move ahead and put these work requirements in place if states request a waiver to update how they deliver Medicaid services. And so currently there are 15 states that are actively pursuing work requirements. States that already have them in place are Indiana, Arkansas, and Kentucky. States that have waivers that are pending right now that they've applied to the federal government to institute work requirements in their states are Arizona, Kansas, Maine, Mississippi, New Hampshire, Utah, and Wisconsin. And then other states that haven't applied yet but are thinking about it and have made their intent known include Alabama, Louisiana, North Carolina, South Carolina, and South Dakota. So we've got some states in here that expanded Medicaid, some states that didn't, but the result of these, let's go to the next slide, the result of these work requirements are that people lose their coverage. And so I talked earlier about, there's the idea that people should have to work to get a benefit is kind of ingrained in the culture, also with that desire to look for ways to punish other people. But that's why we talk about Medicaid work requirements in this way. As Medicaid cuts in disguise, we talk about how losing your health insurance is too high of a price to pay for an error in your paperwork, and that, and this is a really important point, taking somebody's health insurance away does not help them work or stay healthy to work. A lot of the folks that are covered through Medicaid expansion, are landscapers, or work at the salon, or are artists, or people that it's hard for them to get a regular paycheck to even to have that paper trail to document that they are working, or doing activities that are important and contributing to their communities. So a good story is Jody, who's a single mom of 4. She lives in Oakdale. She has chronic health issues. She works part-time in a cafeteria. Her hours allow her to take care of her kids, get them to and from school, and be there with them. But they wouldn't be enough to satisfy the new work requirements. She would not qualify for one of the exemptions. So, so these are a bad deal for Pennsylvania. As I said, the bill could pass in the House. It would move on to the state Senate. If it advances there, then it would be up to Governor Wolf to veto it. If he does veto it, he'll need to point to grassroots opposition. So that's what we've been working to help lift up. Okay, so I want to talk now about so the common thread between work requirements and what happened in 2011 around access to oral health care is that when you put more hoops in place, fewer people are going to get services. So we saw this with Act 22 in 2011, which put new limits on the Medicaid dental benefits that adults could receive here in Pennsylvania. The goal was to control costs, but actually what happened is that it resulted in an increased use of emergency room services and an increased use of prescription painkillers for people that had untreated oral health issues. So this is a problem and a campaign that we're actively working together with Achieva to fix. We just launched the My Teeth Matter campaign. Our website is myteethmatter.org. You can go there, you can sign our petition, you can share stories of people that you know who have suffered because of lack of access to dental care. And so we're building a grassroots effort, collecting stories, working to demonstrate the harm that this change has had on Pennsylvania individuals and families so that we can roll back those cuts and, essentially restore those services and make them available again to adults who get Medicaid in Pennsylvania. So I want to talk next about what benefits are covered now. And also make a pitch that this is our statewide helpline number. I'm not sure what page this is on the printout, but you can reach one of our navigators directly. They also answer text at this line. So some people are more comfortable texting rather than talking on the phone, or at least to set up a phone appointment, you can also text the number. Folks are pretty much always there. We have a team of navigators. I think we have 8 now across the state. So, usually get a call back with somebody within a day. So currently, dental benefits that are available under Medicaid now, checkups and cleanings, but just once every 180 days. Diagnostic, restorative, and surgical dental procedures, prosthodontics, and sedation are all covered and don't need any additional approval. Services that are covered but require some authorization include orthodontics, complete and partial dentures, surgical extractions, and the placement of a device to facilitate the take a tooth out, the eruption of a impacted tooth. And then this next category I'm going to spend some more time on because these are services that are now subject to benefit limit exceptions, and that's the technical term for the restrictions that were put in place in 2011. These benefit limit exceptions say that you have to, and we'll talk about the form, but you have to, your provider actually has to verify the medical necessity of getting an additional exam and cleaning if you want more than one every 180 days. If you need additional dentures, usually it's 1 set per lifetime for dentures. If you need crowns or adjunctive services, periodontics for work on the gums and bones, or endodontic services inside the tooth, things like a root canal. These are all services that are subject to the new benefit limit exception. So as I said, there's a form that's available at the Department of Human Service website that a provider would have to submit on your behalf as the person needing the service. Department of Human Services would decide within 21 days if it's a service that you need currently and are trying to schedule. They would decide within 30 days if it's something that you had to get, and they were negotiating whether or not or how they would pay for it. So these services are covered if the person has a serious chronic systemic illness and a denial of that benefit limit exception would jeopardize the person's life, or if the denial of the benefit limit exception would result in a rapid or serious deterioration of a person's health. Also, if approving the exception is a cost-effective alternative for Medicaid, so if it would be cheaper than another course of treatment that would be required if you don't provide the dental service. And then finally, they're approved if they are required to comply with federal law. So this is a really difficult process for people to go through. A lot of people aren't even aware. You know, I think the tendency is to just accept the first no that you get when you're trying to access a service unless you have an advocate or a family member who's really involved in your care. So this is a really serious issue. And like I said, through the My Teeth Matter campaign, the website, and we developed a dental survey that we use at our outreach events and education events about how Medicaid works for people that are newly enrolled. We're collecting those stories and building out a campaign so that we can go to the state legislature and push them to restore these cuts and improve access to oral health care in Pennsylvania. So just like oral health is a part of health, so is housing. The World Health Organization identifies housing as a social determinant of health, which means it's an underlying contributing factor to health outcomes. And so just raise your hand if you've ever worked in the housing or homelessness field or helped people try to get into safe housing. So again, really complicated, really hard, patchwork of resources that really are inadequate to meet the need. And without a place to sleep, someone can't keep track of their medicine. You know, we hear stories of folks going into shelters and their medicines are stolen, can't keep track of appointments. It's hard to complete an application if you don't have a regular address, or it can at least delay it. So there's really strong evidence that supports that supporting housing services to people not only helps people stay healthy, it also saves money. So even investing in paying for new services to help people find and stay in safe, affordable housing still saves money, and we're going to talk a little bit more about that. So there's significant health consequences of homelessness. There's a whole body of research about this. And so in terms of our agenda of care outside the doctor's office, we wanted to start with housing, you know, and really talk about housing as health, fundamental to people's health. So what are supportive housing services? In 2016, the Federal Centers for Medicare and Medicaid Services defined supporting housing services as those that promote housing success, foster community integration, and develop natural support networks. So there's four main areas of supportive housing services: general support, things like case management, peer mentoring, crisis intervention. This is not an exhaustive list. There's a full one-pager that I can send via email if you're interested. Independent living services, so training in things like budgeting, conflict resolution, benefits counseling on what services are available. Development of a housing transition plan to help people complete, you know, a search to look for a place to live, apply, gather all the information, and also move in. And then tenancy sustaining services, which educate people about, you know, tenant rights and responsibilities, how to be a good tenant or neighbor and resolve disputes. These are services intended to prevent eviction. So Janice talked about how Medicaid is funded as a partnership between the states and the federal government, and that, well, the federal government, only one, thankfully, but the federal government sets these broad rules, and then states can apply for waivers or essentially lay out what kind of benefits can be covered in their state by Medicaid and which groups of people can get them. So Pennsylvania has the authority to say, we'd like to cover some of these supportive housing services for these groups of people in Medicaid. They would have to get approval for the federal government. So Pennsylvania does cover some supportive housing services. Okay, but we completed with the Corporation for Supportive Housing, they created a crosswalk or a map of how Medicaid-eligible services align with supportive housing to look at what's available, who gets them, and where the holes are. And so as a result of that analysis, we found that Pennsylvania does cover some supportive housing services and a few of the waiver programs, but they weren't covering people with substance use disorders or behavioral health issues that were below the level of what's diagnosed as serious mental illness. There were also gaps in services that help people retain housing and in case management and also in access to waiver services. So a really good, so in 2016, we started bringing together folks through our Housing as Health Coalition to look at how we could elevate housing as essential to health. So part of what we did is go to you know, ministries and food pantries and homeless shelters and collect stories and understand what just what the reality of people's lives were, where the process was, where the cracks were, and who was falling through them, essentially. So one of the people that we met was Asante in Philadelphia, and he just experienced a significant amount of trauma. After the death of his mother, he had a family dispute that left him homeless. He has 2 sons, one of whom passed away from cancer. So staying healthy for him is as much of a mental struggle as it is a physical one. He said, quote, "In this situation, you're around a lot of hopelessness, a lot of drug abuse. You become desperate on every level." So he's also a type 2 diabetic. He has hypertension, foot and back pain, and struggled for a long time to get access to health care because he was homeless and had trouble applying for benefits. So even now that he has health insurance, he's still homeless. And, the food stamps don't go as far when you can't cook your own meals. And so it just really shows the complexity of the situations people are dealing with when they try to climb out of poverty and of homelessness. And so pushing Pennsylvania to allocate more Medicaid funding for supportive housing services just would significantly improve the quality of people's lives, but also save money, as we found out. So go on to the next one. Those are some of the challenges. The opportunities are, as I just said, to define and strengthen supportive housing services, and then educate providers on what are billable services so that providers could offer these services and then get paid by Medicaid. To include individuals struggling with substance use disorders, and then to push managed care organizations to really prioritize supportive housing in their approach to holistic, whole person care, and any savings that come about to be reinvested in quality housing for people across the state. So as part of pulling together our campaign and figuring out the best way to make these arguments, we know that often, altruism doesn't motivate everyone like it might folks in this room. So we made the business case for covering supportive housing services. The study that we did in partnership with the Corporation for Supportive Housing found that average annual costs for the chronically homeless population are about $37,000. Providing supporting housing services would cost Medicaid about $3,300 per person annually. Nationally, studies show that supportive housing services reduce medical costs by 24%. And so what we found, and this is a really important number, in Pennsylvania, the state of Pennsylvania, by investing in these services for people that are chronically homeless, could actually save $1.47 million in the state budget. So now it is our job to continue creating the political will to implement these changes, because they're good for people, they're also good for the state budget. And we'll go on to the next one here. How does supportive housing save money? It saves money because it reduces the number of days that people spend in the hospital by 23%. It reduces emergency room visits by 33%, and it reduces days in nursing homes by 42%. So the state is continuing to collect data to compare the cost of people who have experienced homelessness but were placed in supportive housing services to help make this case over a number of years and look at the impact these services can have. Pennsylvania, and I'm not going to spend too much time on this, but I'll encourage people to go to this website if housing is an issue that you care about. It's dhs.pa.gov/citizen/housing. So as we were doing our work, Pennsylvania was also working to prioritize housing for everyone in Pennsylvania and those who are most in need. So in May 2016, they released a 5-year housing strategy to connect people with affordable, integrated, supportive housing, and have some specific goals around helping people that are living in facilities but would rather be in the community move back home, to help people that are at risk of experiencing chronic homelessness, or help, and this is a pretty significant and sobering number, help the 46.6% of extremely low-income Pennsylvanians who are rent-burdened and at risk of slipping into a cycle of chronic homelessness. So you can read more about some of the state's housing strategies, but I just want to highlight a couple here. So Pennsylvania did take the opportunity to define supportive housing services to CMS and is beginning to offer some of these services to people that are covered in waiver programs through the Office of Developmental Disabilities and also the Office of Long-Term Living. They're starting to offer the services to people with serious mental illness and substance use disorder services, but that change is in progress, and we really need to monitor that to make sure that everyone who needs these services are getting them, and that people aren't being disqualified because they don't meet the exact right definition or code, as often happens. So there's two main areas. The column on the left is pre-tenancy and transition services, so help for someone to find a safe, affordable place to live, to assess their housing needs, where they want to live, what the barriers are, to help them plan a budget and apply for subsidies, to secure resources for things like a security deposit and those initial expenses, and also safety inspections to make sure that the setting, the home or the apartment is safe. The second category of services are what's called tenancy sustaining services, and these are housekeeping. So once you find it, how can we help you stay there? So skill building on being a good tenant and neighbor, access to community resources, helping someone understand the terms of a lease or a mortgage, and then helping someone manage behaviors that might jeopardize their ability to live in the community. So this is really important work that's happening right now, but our goals for 2018 and 2019 are to give more people access to these services and to have a conversation with the state Medicaid office about extending them to other vulnerable populations, pregnant women, youth aging out of foster care, and people that have chronic illnesses like HIV or hepatitis C. There is a housing stakeholder work group. Raise your hand if you participated in that or knew about it. There's a lot of state work groups that we could have a big impact on, but it's kind of hard to find them. You can spend some time looking on the Department of Human Services website, but this is a really good opportunity. The work group hasn't met so far this year, but in the plan, they say they'd like to meet 6 to 8 times a year, and it's open to social service professionals, families, caregivers, people that have a stake and an interest in increasing access to affordable housing. Another important vehicle or opportunity I just want to highlight are that most Medicaid managed care plans, and I know for sure that the Community Health Choices plans have participant advisory committees. And these are committees that meet often quarterly, and it's an opportunity for the person who's enrolled, their family, a caregiver, also community providers to come in and have face time with the leadership of the plan, the medical director, the director of long-term services, pharmacy, all the other departments within the plan get together in a room, and they get feedback directly from the people that they're serving on what they can do better. I just had the opportunity to go to the orientation session for AmeriHealth, which is one of the Community Health Choices plans, and all the big shots were there. And they listened to providers, and I was there as an advocate, and there was a younger consumer with a disability and his mom who were there by phone. So the plans work to make these meetings accessible, but what our focus is as advocates is making them meaningful. We don't want them to just be a place where people show up and get a nice little lunch and get some glossy materials and go home. We really want these to be an opportunity for people to raise issues around provider networks, around access to specialists, around all the issues that we're concerned about and that come up as we help people access care. So if you're interested in learning about opportunities for participant advisory committees or other structures like that, other state work groups within the Medicaid office, please let me know and I can send you that information. I think there's probably a wealth, I'm sure there's a wealth of experience and insight and knowledge in this room that needs to be communicated directly to state officials. A lot of the people in the state Medicaid office are, career professionals. They're really dedicated to their jobs. They want to do this right, but they can't do it unless they're actively engaging consumers and caregivers and the community. So let's jump ahead a little bit. So Janice talked about some of this. I'm not going to talk a whole lot about it. You have the information in your slides. Part of what we've been doing is affirming and helping people understand how important Medicaid is to paying for long-term care, that it not only pays for 3 and 5 nursing home residents in Pennsylvania, it also pays for people to get long-term services and support in the home so they can live independently. That's a whole other 2-hour presentation and topic we could get into, what's available, how to apply, how to make that system better. So we'll just skip ahead for now. We'll skip through this. Janice talked about who's eligible for Community Health Choices. I just want to be really clear about a couple of things. Community Health Choices does not affect anyone enrolled in the Office of Developmental Programs waivers for home and community-based services. Those folks will continue to get services through the fee-for-service delivery system. It's only for people who get services through the Office of Long-Term Living, like the Aging Waiver Program or ComCare or Independence. Another group of people that are eligible for Community Health Choices have both Medicare and Medicaid. This group of people might not need the long-term services, but they qualify for Medicaid as their supplement simply because they have a low income and low resources. What's very important to know, because this is a big area of confusion, is that Community Health Choices does not change or take away Medicare at all. It's a program that works alongside Medicare, right, because it's Medicaid. It's a new delivery system for Medicaid. So no one has to change their gateway, their UPMC or their United or whatever their Medicare plan is. They'll just get a new card from whatever company they pick, and as Janice said, there's an opportunity to change your plan at any point during the year, so nobody's locked in. So we'll skip ahead a little bit. Skip it. Skip. Okay. So this is the website. There's two websites. This one is on your slide. The other one I'm going to give you is not. So the one that I'm going to give you, please write this down. It's enrollnow.net. So that's a website that has information about the health choices managed care plans across the state. The website for Community Health Choices is enrollchc.com, and that's where you can go and find out more information about the plans, what's available, and coming changes. Both those websites are operated by an independent enrollment broker, which in Pennsylvania is Maximus for now. We don't have any information on the status of that. So we'll skip ahead a little bit. We always encourage people to call the Health Law Project if they have any interruptions or need to file a legal appeal to retain their benefits. And we'll skip ahead. Important point is that if anyone's in a nursing home and they were in there before January 1st, they do not have to change to be in the network of their Community Health Choices plan. They can stay in that nursing home for as long as they want to. For folks that are entering the long-term care system after January 1st in our region, they need to look at, part of the decision they need to make is who are my providers, and does this plan include my providers, including a nursing home? But if folks were already in a nursing home before January 1st, they don't have to worry about being forced out because of a provider network issue. Well, life is an alternative to Community Health Choices. So this is another way for people to get home and community-based services. There are a lot of great life programs in our area, Community Life, like Pittsburgh, Lutheran Senior Life is up in Beaver and Butler County. But this is a way for people to get, home modifications, changes that would make it safe for them to get around, personal care assistance, and also transportation to the Life Center where they could see their providers, have recreation, have meals. So Community Health Choices is one way to get long-term services. Life is another way. You can't be in both programs at once. And then I think this is it. So really want to encourage people to stay in touch with me because there's a lot of opportunities to not only change the conversation around Medicaid and advanced proactive solutions, but just to get the information out about the availability of services. I'm constantly stunned by when I do community presentations. A lot of folks don't know about the Apprise program through the Agency on Aging. That helps people pick a Medicare plan. It's free Medicare counseling. Every Agency on Aging has an Apprise program. Some agencies on aging also have person-centered counselors that can meet with somebody in person and help them or talk to them on the phone about applying for long-term services. So as we're advocating and defending, we also, part of that is just helping people access the benefits that already exist because that shows demand. So I will stop there. I know we don't have any time for questions. One or two? Well, we're happy to stay around and talk afterward. I know we threw a lot at you today, so hopefully you're not too overwhelmed.
Well, thank you both. This is